Hello, everyone, and welcome to today's Triple Tree Thought Leadership session. Before we get started, I'd like to go over a few items to help you get the most out of today's session. You've joined the presentation listening using your computer speaker system by default. If you'd prefer to join over the telephone, just select telephone in the audio pane, and the dial-in information will be displayed. You'll have the opportunity to submit text questions to today's panelists by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will address questions throughout today's discussion. I would now like to introduce Michael Carroll.
Good morning, everyone, and welcome to Market Insights Live. My name is Michael Carroll, and I'm the Chief Marketing Officer at Triple Tree. Today's session is focused on healthcare logistics and the capabilities required to advance healthcare and the ongoing shift to healthcare at home. A quick reminder that the views and opinions expressed in today's conversation are those of our participants and do not necessarily reflect the official position of Triple Tree or our affiliates. To begin today, I'd like to introduce today's panelists, representing organizations across the post-acute landscape. First, Paul DeCosmo. Paul is the CEO of StateServe, a durable medical equipment benefit management provider. StateServe is the nation's leading technology-enabled containment platform for the post-acute market. Sorry, Paul, stumbled a little bit there. Next is Mazi Razulnia. Mazi is the president and CEO of PAC Health, a leading patient engagement platform he launched in 2013. PAC Health provides personalized education, tools, and support for patients. Mazi is also an author of more than 85 publications and holds a PhD in health services admin. Welcome, Mazi. And last but not least is Sherwin Sheikh, founder and CEO of CareLinx. Sherwin, CareLinx is a leading nationwide in-home care platform with over 500,000 professional tech-enabled care providers that can be successfully dispatched to care for patients at any location. I've had the privilege of knowing Sherwin and CareLinx for the past decade, and it's great to have Sherwin join today's conversation. Thanks, Sherwin. And last but not least, I'll introduce my colleague, John Hill, Managing Director at Triple Tree. In his role, John specializes in healthcare services with a focus in the post-acute landscape, behavioral health, pharmacy, and tech-enabled services. A quick reminder, like Lori said, that you can submit questions throughout today's panel, and I'll be coming in throughout today's conversation to field those questions. And John, I'll turn it over to you to begin today's conversation.
Thank you, Michael, and good morning to everyone. Absolutely thrilled to be here and have everyone join us. Got a great group of panelists here to have a great, healthy discussion around the value of home health care and what's needed from a logistical standpoint to make home health a successful care arena. Let me start with a bit of an obvious statement at this point in our healthcare system, is that healthcare is absolutely going home. For several years now, the market has acknowledged that the home is a very valuable clinical setting. It's lower cost. It's oftentimes and many times preferred by our consumers to consume their healthcare in the home, to live, reside, and ultimately pass in the home. This wave of demand for home health services, as I said, has been growing very significantly over the last few years. And frankly, with regards to COVID impacting us about this time last year, that was a tremendous accelerant of the need for high quality home health care services. On the next slide here, what I want to outline, and part of today's discussion, is really what is required to make the trip from an acute care setting to the home successful. It's a very, very complicated and convoluted journey. And a lot of times us, our parents, our loved ones don't have the right information, the engagement, the tools and solutions to make that journey home successful. And as a result, we still have a significant amount of wasteful spend and avoidable readmissions in our healthcare system. It's the need from skilled home health, non-skilled home health, activities of daily living, things like nutrition therapy management, having the right pharmaceuticals and staying true to the treatment regimen on your pharmaceuticals, and non-emergent transportation, for example, to ensure that mom and dad can get to their follow-up appointments post surgery or acute event. So it still remains a very, very big problem in our healthcare system. And again, our panelists today are providing very innovative solutions to drive more efficiency and avoid a lot of those errors in our healthcare system to make home health more formidable. On the next slide here, this is how TripleTree views the world in terms of home health. We call this the kaleidoscope of home health. And this is a more elegant way of looking at all the pieces that need to work together to make home health successful. It's from technology to service to patient information to communication, and how do we seamlessly connect those dots again to make that journey home and allow mom and dad to stay in the home to live, reside, and ultimately pass. So we'll unpack a lot of these elements today, from DME to patient engagement to empowering caregivers to be very important part of the clinical team in the home health setting. And then lastly, I would say this theme and this thesis that we're going to be unpacking today has been clearly top of mind for both strategic and private equity investors. As we see in the next slide, there's been an increasing wave of investment in this arena. Again, skilled home health and non-skilled home health continues to be big areas of spend and focus and consolidation. We're also seeing in parallel increased investments of those ancillary services, those technologies, the communication tools to make this whole system work better. Just yesterday, we saw Humana announce an acquisition of One Home Care. This is a infusion, DME, and capitated model to allow people to get access to infusion, DME, and other home health services in the home. We had Anthem acquire MyNexus earlier this year in April, rather large transaction in the home health arena. From a DME perspective, there's been a number of transactions, including StateServe and Paul and his team acquiring HospiceLink and the initial investment by Blue Wolf Capital. And so there's been a wide swath, and there continues to be lots of excitement and investment in this arena. So with that, we're really thrilled to have this conversation and talk about logistics in healthcare. So to the panelists, maybe let's start with, as I mentioned before, it's almost a year ago that we were all battling and trying to react to COVID, which was a significant accelerant of the move to the home. Now it feels like mid-June that COVID is almost behind us, knock on wood. But just curious, as you guys think about the world, what's your perspective on, as we come back to normal, what has changed with regards to your daily businesses and interactions in the marketplace? And what's here to stay? Excuse me, what's here to stay versus what changes have you all had to make to adapt to this new normal? Paul, maybe I'll start with you. Maybe speak about as your team interacts with caregivers and the hospice patient in the home, maybe speak from a safety and logistics standpoint, how you all had to react to COVID and what is here to stay going forward.
Sure. Well, good morning, everybody. So, at the core of what we do as a DME benefit manager is really bringing the hospital room home. So if you think about, our service, we're entering a patient's home, we're setting up testing or instructing the patient on how to use the medical equipment properly and safely. And so obviously the pandemic, drove huge concerns about exposure and infection control from both, the patient and also the frontline healthcare worker, the delivery technician. So we just saw a massive shift in access to the home, not only in the residential setting, but in the skilled nursing facilities as well. So we found ourselves, reacting to this new environment. And before COVID, we would have never considered the possibility of leaving equipment at a patient's doorstep, but we were getting, requests that became the norm. We also would have never thought about the opportunity to look at medical necessity more traditionally. So, some interesting opportunities arose from that environment, and like the ability to leverage alternative delivery. So, we started to wrap technology around drop shipping and leveraging FedEx same day. We were implementing more of a traditional prior auth process to deal with the supply chain shortages. So as a cost containment platform, we really wanted to drive these efficiencies across the network and maintain them. So we are starting to see a little bit of minor regression in the return to normal, but we've been doing it this way for almost 18 months. I think we've done a pretty good job of standardizing through technology. And so, considering the inflationary pressure that we're all under, I think it's going to be important consideration as we look ahead to maintain these trends. And I think from what we've seen so far, that seems to be the case.
Sure. And how about from a caregiver perspective? It was a very challenging year for the patient's mom and dad, but also the very important caregivers that attend to mom and dad. What has changed from the caregiver's perspective? What additional tools and services are they demanding in this kind of new world environment?
Thank you so much, and happy to be here. Last year was a significant year for personal care services and just home care services in general, as we saw kind of like inpatient utilization go down because of fear of going back into the hospital setting. A lot of patients wanted to receive care at home. They're obviously adopting telehealth services. At the exact same time, there was a huge need for those who had functional needs in the home, like ADLs and IADLs. There was even kind of delay going into the nursing home environment. So we saw a massive spike last year for interest in home care support services, not just from the direct to consumer standpoint, but even on the enterprise side. So last year we had, well, today we have over 1.5 million Medicare Advantage members who have access to CareLinks at some form of a Medicare Advantage benefit, be it supplemental benefit, care management, a transitional care program. And what we saw was patients wanting those services, health plans, and now investing in those types of benefits as well. And the regs were relaxed last year to really enable healthcare to move into the home to better support these patients, especially with high risk that we're afraid of going out, obviously, and rightfully so, out in the environment. And so healthcare had to move home. And just as you would go into the inpatient setting, the nursing labor really helps those patients. In the acute care setting, we've kind of been filling that gap on the home side, helping with ADLs and IADLs. But then while we're there, we're capturing all this rich data that can better arm those remote clinical teams. And it was just really exciting seeing the patients adapt to that, getting comfortable to use technology, us helping them train to use that technology in the home. And I think this is a great precursor, and kind of the foundation was laid to really accelerate that healthcare movement homeward.
Got it. Mazi, how about from your perspective, as we get back to this new normal, what's here to stay versus are we going to snap right back to where we were pre-COVID? And maybe from the consumer's perspective again, and the need to engage with them, are there any new solutions or tools they're looking for that you're experience through your organization?
Yeah, absolutely. Thank you for having me this morning. At PacHealth, we focus on polychronic patients who are considered rising or emerging risk category of members who may become, future high risk members. And in regard to that, a lot of members that we've spoken to want to go see their doctor face to face. They have a relationship with their doctor, but they were taking a lot of advantages of telehealth services in the interim. So I do think that there's going to be some shift back to face-to-face clinician visits. We currently see that already. But I think what is here to stay and what the expectations have shifted is how we've integrated social care services with healthcare services, whether that is non-medical transportation, food delivery, even device monitoring and remote monitoring. So I think those shifts have already kind of cemented as part of the expectations of patients going forward.
Got it. Well, it's a great framework, again, to build on the theme here. And I think it's interesting in terms of the participants we have. We almost have our own little continuum here in terms of patient engagement, empowering the caregiver in the home, and then tools and solutions and technology from a DME perspective at end-of-life hospice care. So I'd love to dig into a little bit more and get further in a perspective on the solutions you're all providing. And maybe Mazi, I'll start with you on this one in terms of your specific, an area that I'm particularly interested in. And I think what the world doesn't recognize is from a nutrition standpoint, it is an incredibly important, part of the care continuum. A lot of time when mom and dad get home, they they don't have the right nutrition in the refrigerator, and that is a big cause for readmission. So maybe talk about your food as medicine program and how you bring that to consumer and how you make that local for them as well.
Yeah, sure. John, I think, it's an unfortunate situation. Many members don't have the right foods or can't access the right foods. And during COVID, people were afraid to go to the grocery store on their own. So what we found is that we needed to integrate that sort of social care service, that social determinant service into the coaching solutions and platform that we have. So we're now able to deliver fresh and shelf-stable food specific to the member's chronic condition while we're coaching the member to any household in the US within 2 days. And this not only starts to build some accountability, but overcome some of the hurdles that members may have, whether it's transportation, the ability to actually cook the right foods, affordability that many members may have. And we're able to do that through ensuring that we have a sustainable and consistent supply chain. So we became a food broker. We're part of the entire sort of food supply chain, as it were, and can buy in bulk and deliver at a local level, whether to personalize that for the members' taste buds, cultural differences that they may have, but also seasonality of food as well, that matters. We've seen great results as a result of the program. We've seen drops in A1C, blood pressure, food insecurity has substantially decreased, and sort of the self-confidence that members need to sort of manage their health in the home has greatly improved.
So Sherwin, maybe building off of that point that Mazi just offered up with regards to the need for nutrition and making sure that gets from point A to point B on time at the right time. From a caregiver perspective and from a CareLinks perspective, how do you play a role in empowering the caregivers to help with things of, such as social determinants of health and nutrition, non-emergent transportation, activities of daily living? How are you empowering that caregiver?
Yeah. So how we support the caregivers is we match them with basically a professional, be it a CNA, a companion caregiver, a community health worker that matches their needs on multiple levels, from disease state, cultural background, language preferences. And really what we're doing is we're sending someone into the home to a patient and member who has real functional needs, who needs assistance with activities of daily living, bathing, grooming, dressing, meals, transportation, med reminders. We're literally the boots on the ground, physical extension of remote clinical teams. But why the patients are opening up their doors is they needed help. So we're going in and kind of serving as a respite relief for that primary family caregiver, helping them understand what is the care plan directive that's going to best help their loved one, but then at the exact same time, allowing them to step back, take care of themselves, recharge. We're not providing long-term support services. We're going in finite hours per week to help the members, but then while we're there, we're capturing real life data, health data that's empowering the remote clinical teams to then wrap around additional services like what Maz and Paul are both doing from DME and then also from a nutritional standpoint that can better support. But how we serve in the ecosystem is literally that functional support in the home, really getting a good, and this was actually a big insight that we had. Pre-COVID, the way that the clinical teams are trying to get all this information was through the phone. And it's very different when you see what the disease state of the patient is by looking at their claims and what you have in your systems. It's very different when you go to Mary's house. She's 85 years old, has had fall risk, lives in a 2-story apartment that has pest issues. She struggles to go up and down her stairs. It's low lit, and she has poor nutrition and foods in the cupboard, and she's not taking her meds. The only way you get that visibility is by sending in a provider who's able to do those functional screens, social determinant screens, really identifying those gaps of care, and then being a provider that can support them with ADLs and IADLs, and then close those gaps when they're physically on site, while helping the families get the respite break that they need to keep going once that intervention visit for the week is gone. So that's I just want to provide the context of how we serve those patients.
That's really helpful, Sherwin. And I think another trend we're seeing in the marketplace is not only, the activities of daily living, but there's also a shift where there are companies trying to address higher acuity patients in the home and higher acuity levels of care, almost a hospital at home type model. And Paul, I know that's been a recent area of expansion for StateServe. Maybe take a couple minutes and talk about some of those partnerships and how you're partnering with some hospital home providers and the role that StateServe plays in that ecosystem.
Sure. So yeah, to your point, we're partnered with a variety of hospital systems that are kind of exploring the new model from Mayo Clinic and Kaiser through our partnership with Medically Home or with the Trinity Health Systems. But it's a CMS waiver program, so it's currently in its infancy. It's tied to specific diagnoses and conditions, but obviously this program gained traction through COVID, and patients got a taste of being able to receive their acute care in the home, and so that's going to be an ongoing trend, obviously. So our purpose-built network really, I think, complements and enables the hospital at home model. The benefit that our partners see with StateServe is our ability to deliver high quality access to medical equipment anywhere in the country within 2 to 4 hours. And so this really does, I think, enable a model like hospital at home when you're talking about high acuity care, and bringing that hospital room into the home. So over time, I think as the payment models are finalized, we definitely see this as a growth channel for the company, and one that really plays to our strengths.
As you guys all answered my questions related to this, I started thinking about some potential opportunities for you all to collaborate, because it feels like there's some strong connection points in terms of what you all are doing. I'll throw a jump ball up there before Michael jumps in here with a question that is coming from the audience, but I'm gonna throw a quick jump ball out there in terms of do you guys have ideas about how potentially you all could collaborate and partner to make healthcare logistics more efficient?
Yeah, I'm sorry. I'll start if that's helpful. As we're engaging the member via text, email, phone, and really being the eyes and ears of the healthcare provider in between clinic visits, we hear a lot of things. I mean, a lot of members want to tell their story, and because we're providing non-clinical services, they're much more open to having a conversation with a certified coach than a hierarchy of clinicians. So I think one area for us is, for example, ensuring that if Ms. Jones would like to receive DME services, we can connect them directly to StateServe, or with CareLinks, once they've completed their visit, face-to-face visit, we can become the virtual engagement for that member, and ensure that they're being accountable to some of the areas, or ensure that we can actually communicate with them on a more regular basis. So I think with all of these, John, it's daily contact that we're finding to be a highly important way to resolve the members' issues in the home.
Got it.
I got an opinion on that one, and that is we're all capturing data and sending it back to our sponsors who are paying for us to go support their members. And I think there's an opportunity for us to basically coalesce our data in a more digestible way that allows us to, if we're all serving the same members, one, identify, as Mazi just mentioned, that we are serving the same members. Therefore, let's have a holistic picture from what they're capturing, what we're capturing, that then will inform our sponsors of what's the real true picture of this member that we're serving in the various different ways. And I think that's through just open APIs, us getting our sponsors to allow us to start communicating interoperably with each other, and then allowing them to basically manage the populations more holistically rather than individually going to silos, because we all know that they wait a while to push everything into their systems. And so have everything more real time at a holistic view of all the touch points that we all have individually. I think that's going to be very important long term.
Yeah, I think the national scale, I think that's represented here on the panel, really gives us an opportunity to look at, not just the data sharing, but bundling those services on some level on behalf of the payers. So I think there's, a tremendous opportunity to take costs out of the system through data sharing and leveraging each other's logistical capabilities at a national scale. So I think there's, potentially some exciting things to explore offline.
Awesome. Thanks, guys. Hey, Michael, thanks for keeping us on our toes here. You had a question from the audience?
Yeah, I think it just builds on the conversation about collaboration. So the first question is really directed more at Mazi, at you. You talked about food as medicine, and obviously healthcare is local. So how do you source those local partners to actually make that program work is the question. And then two is a follow-on around kind of reimbursement. How does the member pay for that? And I think then Sherwin also kind of directing that question to you, because obviously CareLinks has gone from, you still have that direct pay option, but you also have that now embedded MA option. So talk about reimbursement a bit. So Mazi, will start with you, and then you guys can just talk about reimbursement a little bit.
Yeah, so actually we have a collaboration with a national distributor to deliver the right types of food to the member at a local level. And what we found is that there's a lot of local providers, food banks, et cetera, but again, accessibility, the fear during COVID, and the inconsistent supply of food was a big issue. And so we're able to buy in bulk and deliver locally to that member. We create specific menus that they can choose, and it's always rotating because people don't want to eat the same thing over and over again. So that's been an important finding. As far as who pays for it, we've found that payers have started to value that nutrition and supplementing that as a benefit has great long-term impact on healthcare, but also immediate impact on a member's health in general. So when a member is now feeling like they're full and they're eating the right nutrition, they're willing to take the next step in other behaviors like medication adherence, maintaining a certain accountability to accessing primary care, for example. So we've found this to be a very great solution in kind of combining both the coaching and the food, and almost using the food as part and parcel as an incentive in some way to continue engagement.
Then Michael, on your question related to CareLinks, so today we are nationwide. We have 500,000 in-home care providers, independent professionals, but we also have in some markets affiliate agencies as well that we've aggregated within the network. And really what we are doing is providing one on a direct to consumer, more of that longitudinal private pay care. That's where we started. But where the growth and the focus of the company has always been was being extension of clinical teams. Because when we're going in, we're actually capturing rich data, over 172 data points that we're capturing on behalf of the clinical teams of our sponsors, again, type of HRA, social determinant screens, functional ADL screens as well, to identify real gaps of care, things that are not properly coded or even not even identified that we're finding out in those visits in the home. And then in terms of kind of the payment pathway and why and how we've been able to, like, as I mentioned, we have 1.5 million members today. Next year will be over 2.5 million members. And the payers, given the regulatory changes that happened in late 2018, 2019 was the first year that allowed in-home care support services as a supplemental benefit for Medicare Advantage plans. Very few were actually, they were piloting. We were all piloting from discrete markets and really understanding what the value of this is, how much from the payer perspective, what new insights they were going to gain, but then also from the patients and members as well, would they open up their doors? And what they found is with this ADL support, they actually got the members to really open up their doors because we're helping them with the real life needs. And then we're able to capture that data. And so now as from a payment standpoint, no insurer is really paying for long-term support services. What they're doing is paying for a finite number of hours, either a transitional intervention that we're going into the home post-discharge for the first 2 weeks, where we're helping the families understand what the care plan is, helping them train them on the tech, help them with meals, mobility, transportation back to the first appointment visit, getting medication from the pharmacy, and and trying to be that real support for a safe transition. And the plans are paying for those hours, and their ROI is around reduction in 30-day, very basically avoidable rehospitalizations post-discharge. And then on the supplemental benefit side, they're paying for finite number of hours. We're seeing in the market anywhere between 8 to basically up to 20 hours per month per care. It's not a lot of care, but when we're going in, we're helping with house cleaning, grocery shopping, errands, going to the pharmacy. We're basically acting as that surrogate family member. And then getting the data for the health plans. Again, this is a big data play for them. And then after those interventions, those who still have ongoing functional needs through a value add type of benefit through the health plan, we're discounting the services that they can procure privately going forward. And so that's when we look at it, the plans are doing targeted interventions. And then what we do is identify ongoing need, discount services, and then have them pay privately going forward. So that's kind of how the payment structure has been working as the regs allowed health plans to innovate here.
So guys, one of the key elements that has been part of all of your answers so far to make this all work is data and patient information. And as we were getting ready for this conversation, Mazi, I remember a comment you made with regards to really make this work, we need to put the consumer in the middle of healthcare. And if you think back to that kaleidoscope that I showed earlier on in the onset of this conversation, I think that really depicts what perhaps you were mentioning there in terms of putting that consumer in the middle of healthcare. Maybe opine a little bit more on what exactly you mean and how patient information and data plays into that equation.
Yeah, sure. I mean, if you look at healthcare globally, you basically have your claims data, your lab data, your EMR data, and pharmacy information, and generally, and you can device data as well. But generally, what's missing is how the member is feeling, doing, quality of life, how they're thinking, what their home environment is like. And that's very difficult unless you're either engaging the member face to face or virtually setting up a relationship with them. And I think what all of us are trying to do is trying to characterize and taking a very big picture view and creating a systematic approach to collecting valuable information. So we collect over 150 pieces of data as well, anywhere from mental health status to distress. One of the areas that we cover is financial distress, and how well is the member, how concerned is the member around their finances related to their healthcare? Are they able to afford their medication? Are they worried about copays, their premiums, things of that nature? And that has a lot to do with then the decision making that goes on in accessing care, taking their medications as recommended, or buying the right types of food. So for us, and I think Sherwin said it earlier, if we're collecting this information and able to integrate it now with claims and pharmacy and clinical information, you start to get a much better picture of both the clinical environment and the home environment for us to then target the right types of interventions and services and really improve the member's experience. People don't want to get pinged around everywhere. They want that data to work for them and not be asked 100 times around what insecurity they have at this time.
Yep. And Paul, from a hospice perspective, it's clearly a very sensitive, stressful time in everyone's life journey, not only for the patient, but the family and loved ones. And as you mentioned before, from a KPI perspective and logistics perspective, you have to get that DME equipment in the home within a matter of hours, right? And in a pre-COVID world, I'm sure there's a lot of interaction with the family and the patient with regards to setting up and educating the patient on that piece of equipment. Maybe speak a little bit with regards to a new initiatives at StateServe with regards to leveraging patient information and patient data to help accelerate and drive efficiencies in what piece of equipment, what portfolio of equipment is ultimately provided to that patient in the home.
Sure. Yeah, so when we think about the nature of our service and what we do and improving the patient experience using data, the first thing that comes to mind, because we're so involved in that initial admission, is limiting the patient disruption. We don't want to be going back out to the home, subsequent times in the initial week of the admission. Like you mentioned, it's a pretty sensitive time. So at StateServe, we've got a pretty well-rounded view of our patients through the EMR integrations, and also what we've collected in our own proprietary databases over the past 15 to 17 years. Diagnosis, care setting, the patient's height and weight, just a couple simple examples that go along with looking at what a patient needs. So we're able to take these various data points and predict really not only what the patient might need today, but over the course of their hospice journey. So today we use the system. We've developed proprietary algorithms to really make recommendations to the clinicians during the admission process, and leverage this to the vision of the future, which is a zero-touch ordering process, to fully automate everything the patient might need in one delivery. And so we see multiple benefits to the approach. We obviously minimize disruption to the patient. We contain the cost by standardizing the process and reducing the trips, but we also save time for our clinicians by automating the admission of a new patient. So we think this approach to leveraging data into predictive analytics is a win for our stakeholders, in an area that we're going to continue to make investments in over the long term.
And Paul, a quick follow-up to that one. As you think about a hospice patient, they need their DME, but they also need the pharmaceuticals to provide comfort care in the home. Are you partnering with PBM or pharmacy companies to marry up the DME and the pharmacy together from a predictive analytics perspective?
Definitely. So we've integrated with both supply vendors and pharmacy. Those are the key vendor lines within the hospice care setting. To data share, to provide a single pane ordering experience for the clinicians. And we're seeing some interesting benefits come out of that. I mean, for example, when you crosswalk data with pharmacy, you start to notice things and checkpoints in that data. For example, does the patient, have they ordered fall prevention equipment, and they're also prescribing anticoagulants? And so, there's just that's a small example of, what we were talking about earlier in terms of sharing data, being more integrated and connected. And so, we've made steps in that direction, and we're going to continue to invest. We see a lot of value in that, and so do our clients.
And Sherwin, maybe over to you. I mean, one of the challenges that was raised here is, the home being a very valuable clinical setting because of the wealth of information that you can gather in the home in terms of what's in the refrigerator, what's in the medicine cabinet, are there fall hazards, and other social and environmental conditions. And you've been, I think, very articulate around needing to share that information through open APIs. Maybe give us your perspective on the role of the caregiver and what types of and depth of information that the caregiver is allowing you to collect and ultimately share with the different constituents in this ecosystem that will ultimately make that journey better for the consumer and the caregiver.
Yeah. For those that opt into our program, they're the patients and members who have progressed to the point where they can no longer care for themselves, and or their loved ones need a respite break. And so it's a population that is open and willing to have us come in. They first start out with basic light support. So it's usually, hey, can you help with light housekeeping, laundry? You go to the grocery store, pick up these errands, and then we build trust. We don't ever push. In the data that we're collecting, it's very thought out based upon disease state. So we talk about the 172 data points, but it's also customized by disease state. So an Alzheimer's specific program where we're just trying to track and reduce decline as much as possible for that patient longitudinally, to very specific around CHF, COPD. So there's very specific tasks that we're capturing, but it changes throughout our journey with them. So a lot of these benefits are on a supplemental benefit side, where it's between 8 to 20 hours per month. And depending on month one versus month 6, we have built a very different relationship with that patient and member, including at some point, we're helping them with very intimate things that they won't let us do at the very beginning. And that is helping them with bathing, grooming. They talk about their vulnerabilities that at the beginning of the engagement, they don't share that. And these are things that just evolve as the relationships evolve. And then they see us as an advocate. Really, we're there to support them. And it's just, honestly, it's beautiful to see how much they open up and they see the value of having this support mechanism around there. They do know it's finite in nature. We're coming in and look forward to the next visit. But as a result of that, they know that the genuine intent of all these investments is to keep them healthy at home as long as possible. And that is why everyone's investing in this. And so as they see, that's what the real intent, even with the data that we're capturing, that's the end all mission, is help them stay home with dignity, grace, and stay healthy. And with that, they allow us to capture more and more rich data, which then we tell them, hey, your plan has these tests that we can send to your home for A1C. You're not taking advantage of this. Can we help you with this? And then the plans start giving us other benefits that the member was eligible for, that they haven't been taking advantage of. We just don't throw it to them right away. It's like we identify what are the key ones to really move the needle. And then we basically help them with that engagement process, including devices in the home. Like a lot of these devices were shipped into the home that the members don't use. And so what we do is, why? What are you worried about? Like, this is what the intent is. If you continue to track this, we're able to, basically your remote care manager is going to have a lot better information to care for you at home. We train them, we built the right habits and routines. And it's, in the end, it comes back to, we're human beings, we're social beings. And once you build those relationships and they understand the intent is to care for them, they open up. And then we're able to really impact outcomes as a result of it.
Sure, that's really insightful. Appreciate that. Maybe before we move off this data topic, I'll just throw it out to the group again. Any other points, Paul or Mazi, you want to make on the importance of data in this whole equation? And Sherwin just talked about building that relationship and trust. It's hard to do, but with right communication and information, you can overcome that. But it's a key component of this whole equation. So any other points you all want to make on data capture and share?
Yeah, just to put an exclamation point on what Sherwin said, it's the relationship before the data. And oftentimes in healthcare, we want the data and then everything else will come. It's the other way around. If you build the relationship with the member, then you start to get actionable data. And I know Sherwin probably has the same philosophy. We don't collect data for the sake of collecting data. We're collecting data so that we can actually tailor and personalize the right services and the coaching and the support going forward.
Hey, John, maybe one add-on to your question, and it's a question from the audience here. How do you think about democratizing the data? So let's say that you're all collaborating and sharing and working together. How do you make that data more longitudinal and share that?
Definitely would have to be de-identified. Like, we would have to get the blessing from the sponsors, but I think it's significant step in the next direction. We do know that our sponsors are aggregating all the data and they're trying to do good with that data. It would be great if we can start sharing our data and having others benchmark around it. But I mean, there's a lot that could come out of it from a research standpoint, building better care plan designs by disease status. We really want to extend more healthcare to the home. It's like, okay, these interventions led to this outcome, and we can actually see all the interventions, not just what we did, but what everyone did, and this is what the outcome. Ultimately, that's what needs to happen. And we just need to get our sponsors to allow us to do that, because I mean, ultimately, a lot could come from that. So yeah.
I think there's also, John, a duality there. I think certainly it's the sponsor, but I also think that this data has some level of ownership by the patient. So if they, for example, in our engagement, they consent for us to share their information with their provider, with a caregiver, or with someone else in that kaleidoscope that you all provided up front. So there is some level of control, as it were, that we give the patient to say, you know, would you be comfortable for us to share this level of information? You know, not necessarily just to the plan. I also see the value in this data, kind of fast forwarding to building better clinical trial endpoints. So as medications are coming down the pipe, you want to better understand how they are impacted in a more real world setting and what types of information we may want to collect during even clinical trial phases, not necessarily in a post-acute setting.
And Paul, it's interesting, maybe from again, more of an end of life journey, moving from home health to palliative care and ultimately end of life hospice care. Are there opportunities you've thought about in terms of, you move upstream in terms of providing, you know, DME in the home setting, DME for individuals that are transitioning to palliative care, and so you're owning that journey a little bit sooner, and you're capturing that information. It's more of a longitudinal relationship versus I'm a member on a Medicare Advantage plan. I, you know, unfortunately become eligible for hospice service, then I become a Medicare, you know, fee for service patient, and I transition to the hospice benefit. I mean, how are you thinking about perhaps, you know, owning that journey and providing services and DME and supplies earlier in that journey?
Yeah, I mean, we're obviously looking at those different verticals, and that's, you know, an important piece of our growth plan for the future. But I think just beyond the data and the expansion of the company, you know, back to the disruption of the patient, when you're picking up and delivering medical equipment, the sooner that we can have access to that patient's medical journey, the more that we can limit disruption along the way. So typically, you know, when we see patients come from home health into hospice, they've already had equipment. The way that it works today, you know, the home health DME provider is picking up that equipment, and we're bringing in more equipment and just disrupting their lives. They're oftentimes, you know, requesting the same equipment that they had prior. So I just think it makes sense from the patient-centric standpoint on so many levels, you know, just beyond obviously the business justifications for doing it. But it's of high interest to us, and we're always trying to keep the patient at the forefront of our service.
Yeah, I mean, that one to me almost sticks out like a sore thumb in terms of, you know, why are we having two different companies, you know, engage with the member in the home, drop off a wheelchair, and then, you know, they're transitioned to the hospice benefit and they're getting the same wheelchair, but it's delivered by a different company and paid for by a different payer.
That's right. Yeah, and that's what's driving it. You know, at the end of the day is who's paying the bill. And so, you know, to the extent that we can integrate more seamlessly across the spectrum, I think it will add value to the patient at the end of the day. So, yeah, it's ludicrous on many levels.
But also creates a big opportunity.
Yes, it does.
Yep. So regulation is everywhere in healthcare, obviously. So maybe I'll throw a jump ball out there with regards to how a regulation and regulatory change has impacted your strategy at your businesses. You know, Sherwin, as an example, you talked about you know, activities of daily living being carved in as a supplemental benefit to Medicare Advantage. Maybe we can use that as a starting example. But let's talk about how either historical regulation or some potential changes out the windshield are influencing the way that you guys strategize and grow your business.
Let me start first. And so as you described on the Medicare Advantage supplemental benefit, I think that was a huge win for the industry. And I know that it was many years in the making to actually make that happen. But what we've seen since then is an accelerant of changes in regs that allows more flexibility From just in the past, it was a uniform benefit. If you had to put one benefit out there, everyone had to be eligible. Now you're seeing changes that allows our customers that on the payer side to customize intervention by disease state, and it's just giving a lot more flexibility on ways that programs can be delivered, and you can then vary those benefits based upon need. And that's really helping pave the way of these interventions, because in the past you had to just do everything equally for everyone, and now you can have these more targeted, even sometimes significantly more robust and valuable benefits, because they have multiple chronic conditions, comorbidities, they need that support in the home. It's great to see the traction that's happening. COVID also obviously did help in a lot of ways, and just relaxed the window. Usually you had your annual filings that they have to go through on their plan designs, but if there's any way that they can support the members at home during the pandemic, they were allowed to, which that allowed for a lot of innovation, a lot of testing. And now what we're seeing when we're coming from the backside is a lot of interest to further expand these programs because they saw the value of it. Another one, just when you look at all the services that we are doing, it really makes sense for risk-bearing entities. So those who are trying to reduce inpatient utilization and drive down cost of care. Other recent innovations that are in regulatory changes on the direct contracting entities, these primary care models at home. I think that is going to be a huge additional. So you talk about what we're doing from a strategic side, is these primary care home models make a lot of sense from outcomes perspective. It also doesn't make sense to send a doctor door to door to door and pay for windshield time. So how do you smartly use all these touch points as we're doing as an extension of that clinician? And yes, when it makes sense, send the physician to the home of the patient, but it doesn't need to be the end all be all. And so when we're looking at how the models are evolving from a risk-based perspective, I'm significantly bullish on these direct contracting models, but it needs to be smartly done, that we can leverage the entire ecosystem to minimize that MD windshield time or NP windshield time.
And John, in our world, we've tied a lot of our services to Z codes that are being discussed, and we see the eventual path of coaching to be a reimbursable event. So there's now a taxonomy, and the AMA has approved the ability for individual coaches to receive an MPI number, just like any other clinician. And so the next phase of that is then tying claims and reimbursement codes to coaching services, along with these social services that are integrated. So maybe a year, maybe 5 years from now, but the pathway has been set. First, to describe the industry. Second, to create a taxonomy. Third, to create a certification process and program. And now with the MPI number that was announced in April.
Awesome. I guess, Paul, for you, the hospice world has been, from a regulatory perspective, probably frankly one of the most stable environments in our healthcare system. There's been discussion around the Medicare Advantage carve-in. How are you thinking about that as it relates to the DME services?
Sure. Yeah, so I mean, it's obviously the carve-in's off to a slow start in terms of major health plan participants, but over time, obviously we're going to see it move that way and see greater adoption. So today, we specialize in full risk capitation and cost containment. We think that those are two things that are going to play well in the Medicare Advantage carve-in environment. Obviously, we'll need to continue to make investments in our platform on the claims management side to more effectively integrate with payers. But I think, our national scale, ability to take risk and contain cost are transferable benefits to that environment. And I think it gives us a big growth opportunity here.
Fantastic. Just keeping an eye on the clock here, guys, with about 5 minutes. I thought it'd be fun to throw out a lightning round topic here. So please excuse me as I read it out here so you guys fully hear it and can react accordingly. The question is, when you think about your businesses and the need to wrap around and support the patient beyond what your organization already does, what's the most important priority or challenge that needs to be overcome going forward?
I'm happy to step in first if you like. For us is integrating those last mile services to create a seamless member experience. There's not a patient that we've not engaged that just says, I only have diabetes and I only want to control my A1C. They have a long list of areas that they want help on, and they'll open up with once you start building that relationship. So instead of just sending patients and referring them like, you know, your cell phone service does, we want to make sure that there's a better experience, that there's a quarterback, that there's a buddy, a health advisor that is really backing you up and can really personalize those services. So the integrations is key for us.
Thanks, Mazi.
Yeah. I would piggyback on that and the topic that we discussed earlier with regard to, you know, crosswalking data across lines of service. I think that's so valuable, both from cost containment, but also from an outcome standpoint and the way that we can better service our patients. And so the continued focus for us will be on developing and enhancing those integrations and automating some of, you know, what today is unnecessarily complicated process to admit patients and care for patients, whether it be at end of life or in any care setting.
And then on mine, clearly you're hearing a common theme here. One of the benefits, one of the areas I see is actually knowing clearly what the members are eligible for. What truly are the benefits they have? And what's surprising is we see a lot of redundancies with the various programs. And I just realized that if we were able to get a clear picture of what these patients and members actually have access to. So then while we're providing our services, then we can actually truly wrap around. Right now, we're having to do a lot, we're getting smart on our own by pulling all this information ourselves. But I think there's something that can be built, or like even our sponsored organizations, when we get the member eligibility file, we can actually see what are the other programs and services more clearly that they have access to, that they have not been engaging, instead of just telling us, hey, they haven't been engaging in this one, can you please move the needle here? And so it's getting that more holistic picture of what we can truly wrap around them. And then since we have that relationship with them, we have the best insights of what their needs are, we can then help empower, okay, you should take advantage of this program. And this is why, given your specific needs. And we could become a better advocate. But in the end, our sponsors should want that because the outcomes will be improved. And so while there might be higher utilization on certain benefits, net, the patient will be lower cost long term. That's what.
Well, guys, this has been a great discussion. Congratulations to you all in terms of the progress and the growth that each of your companies has made to date. We look forward to continuing to watch your businesses grow and thrive and provide solutions in this post-acute marketplace, which again, is really in dire need of better logistics and efficiencies and wrapping both services and technology and information around that patient. So with that, thank you guys for a great discussion. I'm going to turn it back to my colleague, Michael Carroll.
Thank you, John. Thank you for having us.
Gentlemen, I'll add my thanks to Paul, Mazi, and Sherwin. Great seeing you, and congratulations, and thanks again. That concludes today's Market Insights Live session. If you'd like to watch a replay of today's session or any prior session, you can visit the Strategic Insights of TripleTree's website at triple-tree.com. And then also a quick reminder that we've got 2 upcoming Market Insights Live sessions, and we have one next week, and not Tuesday, it'll be on Friday. And that one is focused on value-based care in a post-COVID world. So thanks again for joining us today, and have a great rest of the week.
Thank you.
Thank you.